Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Respiratory diseases are very often found in children. The important risk factors associated with respiratory diseases include malnutrition, low birth weight, climatic variations, overcrowding, poor ventilation, air pollution, lack of enteral sanitation. Pediatrics diseases of the respiratory system. Common clinical features related to respiratory diseases are cough, dyspnea, chest indrawing, chest pain, cyanosis, wheezing, stridor, grunting. Pediatrics diseases of the respiratory system. 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 Classification of RTIs. Depending upon the site of infections of respiratory tract. Upper respiratory tract infections. Common cold. Rhinitis. Nasopharyngitis. Pharyngitis. Itis media. Sinusitis. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Classification according to cost of organisms, e.g. cost of agents of pneumonia, bacteria, pneumococcus, staphylococcus, streptococcus, H. influenzae, Klebsiella, M. tuberculosis, E. coli. Pediatrics diseases of the respiratory system. Viral, influenza, measles, chickenpox, respiratory syncytial virus RSV, mycoplasma, mycoplasma pneumoniae, fungal, candida, coccidioidomycosis. Pediatrics diseases of the respiratory system. 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 Branhemelicadoholes, Staphylococcus aureus. Clinical manifestations. Acute stage. S/S of a cold that do not improve after 14 days. Low-grade fever. Purulent nasal discharge. Nasal congestion. Headache. Tenderness and feeling of fullness over affected. Pediatrics diseases of the respiratory system. Edema over the affected sinuses. Halitosis. Cough. Chronic stage. Intermittent low-grade fever. Purulent nasal discharge. Sneezing. Impaired sense of taste and smell. Halitosis. Malaise. Pediatrics diseases of the respiratory system. Pathophysiology. Acute sinusitis occurs when the sinus cavity is invaded by bacteria causing mucosal inflammation and edema that block narrow sinus channels. Increased volumes of secretions are produced, and the affected sinus is filled with purulent material. Inflammation and infection interfere with the protective cleansing action of cilia covering the pediatrics diseases of the respiratory system. Impaired mucociliary transport leads to stagnation of secretions within the sinuses and provides a medium for bacteria growth. Chronic sinusitis is usually a complication of acute sinusitis. Prolonged or repeated infections result in irreversible changes in the mucosal lining of the sinus. Nasal polyps, deviated septum, and enlarged adenoids inhibit sinus drainage, increasing the pediatrics diseases of the respiratory system. 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 Allergic rhinitis. Inflammatory content of nasal mucosa with pattern of seasonality, recurrence and specific triggers. Commonly called allergic rhinitis, hay fever. Pathophysiology. Allergens such as pollen, molds, spores, dust, mites, animal dander are deposited in the nasal mucosa. Local IgE is produced and sensitization of pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Etiology. Predisposing factors commonly are dust, mites, feathers, dander, mold spores, pollen, grasses, weeds. Pediatrics diseases of the respiratory system. Clinical manifestation. Watery rhinorrhea. Paroxysmal sneezing. Itching of the nose, eyes, ears, and palate. Allergic salute, upward rubbing of the nose which can leave a crease below the bridge. Allergic shiners, dark circles under the eyes from congestion and edema. Dry lips from mouth breathing. Pale boggy nasal mucous membranes. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. MX. Rx of choice is to eliminate the allergen from the child's IMT. In case this is impossible, medications can be given. Antihistamines. Bronchodilators. Decongestant in case of nasal congestion. Topical corticosteroid, e.g. clombazone. If no response, systemic corticosteroids. Pediatrics diseases of the respiratory system. 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 Pathophysiology. The immature anatomy of a child's middle ear and eustachian tube predisposes infants and toddlers to otitis media. When the eustachian tube is obstructed, as frequently occurs with enlarged adenoid or mucosal edema from an upper respiratory infection, effective drainage and ventilation of the middle ear cannot occur. Air that is normally present in the middle ear is absorbed by the blood, resulting in a vacuum or pediatrics diseases of the respiratory system. If the eustachian tube remains non-functional for one period, the fluid within the middle ear becomes thick and dark in color. Glue ear. Mild temporary conductive hearing loss often occurs in otitis media with effusion due to decreased mobility of the ossicles and the tympanic membrane. Permanent conductive hearing loss may result from repeated episodes of otitis media and may interfere with the depth of language and cognitive. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Purulent fluid accumulates in the middle ear, space causing pressure and pain. Otitis media with effusion may proceed to follow. Acute otitis media. Complications of otitis media. Conductive hearing loss. Mastitis. Meningitis. Brain abscess. Tympanosclerosis. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Clinical manifestations. Acute otitis media. Otology. Earache. Infants may pull their ears or roll their heads. Irritability. Sleep disturbances. Persistent crying in infants. Fever. Vomiting. Anorexia. Diarrhea in infants. Tympanic membrane appears bulging, opaque. Usually red, with decreased mobility. Light reflux. Pediatrics diseases of the respiratory system. Drainage, usually yellowish-green, purulent and foul-smelling, indicates perforation of the tympanic membrane. Otitis media with effusion. Tinnitus, popping sounds. Hearing loss. Delays in speech may result from prolonged hearing loss. In older children, hearing loss may manifest as behavior problems, poor school performance. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. MX. Oral antibiotics amoxicillin/clavulanate augmentin. Erythromycin/sulfasoxazole pediazole. Trimethoprim/sulfamethoxazole or cefixime or cefaclor. Given for a total of 10 minutes 14 days. Prophylactic antibiotic Rx after initial Rx for 6 months. With Amyxil or sulfonamide. Acetaminophen to relieve pain and fever in acute otitis media. Antihistamines. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Acute nasopharyngitis. Common cold. It's a viral infection of the URT, usually self-limiting. Can spread to surrounding structures such as the middle ear and the LRT. Pathophysiology. Nasopharyngitis occurs when viruses invade the mucous membranes lining the nose and throat, causing edema, vasodilatation, and PDN. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Clinical manifestations. Nasal congestion. Sneezing. Nasal discharge rhinorrhea of first clear and watery may become thick and purulent in case of secondary bacterial infection. Low-grade fever in infants, no fever in neonates. Cough caused by secretions draining into the throat, dyspepnea. Sore throat. Pediatrics diseases of the respiratory system. Irritability and restlessness. Muscular aches. Chilly sensation. Cervical lymph nodes may be enlarged. Infants may be anorexic or refuse feedings, cause of difficulty in sucking and breathing at the same time. Dehydration may result, sometimes vomiting and diarrhea in infants. Symptoms may last a week and start to subside. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Influenza. Flu. Pathophysiology. The main area of involvement in children is the mucous membranes of the respiratory tract, which shows extensive destruction of its ciliated epithelium. There may be marked desquamation of tracheal epithelium near the onset of symptoms, although the main pathology is in the respiratory. Pediatrics diseases of the respiratory system. Etiology. Orthomyxovirus family. 3 influenza virus types, A, B, C. The infection is airborne. Clinical features: chills and fever, flushed face, myalgia, cough, headache. Pediatrics diseases of the respiratory system. 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 Pathophysiology. Infection and inflammation of the tonsils cause them to enlarge. The palatine tonsils may meet in the midline, kissing tonsils and cause difficulty swallowing and breathing. If adenoids enlarge, they can obstruct the eustachian tubes, resulting in otitis media and hearing impairment. Hypertrophy of the adenoids can also block the pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Mouth breathing in a pleasant mouth odor. Fever. Cough. Enlarged adenoids may cause nasal quality of speech, mouth breathing, hearing difficulty, otitis media, snoring, or obstructive sleep apnea. DX. Throat culture. CBC. Bleeding and clotting profile. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Croup. A term used to describe a group of conditions characterized by inspiratory stridor or harsh brassy, or croupy cough, hoarseness, and varying degrees of respiratory distress. The major types of croup include acute spasmodic croup, laryngotracheal bronchitis (LTB), bacterial tracheitis, epiglottitis. Pediatrics diseases of the respiratory system. Pathophysiology. Croup is a viral infection of the URT, although the upper or non-reactive airway is involved to some extent in all forms of croup. Each type is named according to the anatomic area most severely involved. For example, LTB affects the larynx, trachea, and bronchi. In acute spasmodic croup, the larynx is the area of most severe inflammation. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Clinical manifestations. Often begins at night and may be preceded by several days of early symptoms. Sudden onset of harsh, metallic cough, sore throat, inspiratory stridor and hoarseness. Use of accessory muscle substernal, intercostal, suprasternal retractions. Frightened appearance. Agitation. Usually low-grade fever. Pediatrics diseases of the respiratory system. DX. Basing mainly on clinical symptoms. MX. Goal is maintenance of a patent airway. Increased oral fluid intake. Steam inhalation to reduce mucosal edema. Nebulization with epinephrine to reduce laryngeal edema and bronchospasms as in OTB. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Epiglottitis. Acute inflammation and swelling of epiglottis and surrounding tissues. Is a life-threatening, rapidly progressing condition that may cause complete airway obstruction within few HRS of onset. Etiology. Haemophilus influenzae. Staphylococcus aureus. Haemophilus parainfluenzae. Pediatrics diseases of the respiratory system. Clinical manifestations. Abrupt onset. Rapid progression of symptoms. High fever. Sore throat can progress from a mild sore throat to acute respiratory distress in a few HRS. Child appears anxious and frightened. May be irritable or lethargic. Child insists on sitting upright, often in a tripod position, leaning forward supported by arms. Chin thrust out, mouth open. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pathophysiology. Epiglottitis is a bacterial form of croup. The epiglottitis and surrounding structures become inflamed as bacterial infection invades the soft tissue. The epiglottitis becomes edematous and cherry red and may become so swollen that it completely covers the glottis and obstructs the airway. Secretions pull in the hypopharynx and larynx. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Summary. Bacterial infection. Haemophilus influenzae. Epiglottis becomes edematous and cherry red, high fever. Edema severe and painful. Pediatrics diseases of the respiratory system. MX. The main objective of RX is to achieve a patient airway as quickly as possible. Take and monitor oxygen saturation. Monitor ABGs. Administered humidified oxygen. Mechanical ventilation sometimes in severe cases. Antibiotics for 7 minutes 10 days. Investigations. Pediatrics diseases of the respiratory system. 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 Pathophysiology. Inflammation of the trachea and major bronchi are present in bronchitis. Mucus PDN is increased and the mucosa is congested. Due to non-specific leukocyte migration, purulent secretions can occur even in the absence of a bacterial infection. Acute bronchitis is self-limiting disease. Chronic bronchitis in children has been shown to. Pediatrics diseases of the respiratory system. 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 Pathophysiology. In bronchiolitis, edema and accumulation of mucus and cellular debris cause obstruction of bronchioles. Infants' bronchioles are very small and can quickly be obstructed. Airway resistance is increased during inspiratory and expiratory phases of respiration due to the small passages. Hyperinflation of the lungs results from air. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system are usually by RSV. Edema, mucus, and cellular debris obstruct bronchioles. Bronchioles constrict during expiration, causing hyperinflation of lungs. Atelectasis occurs when obstruction is complete. Pediatrics diseases of the respiratory system. Clinical manifestations. Mild urti usually precedes death to bronchiolitis. Serous nasal discharge, sneezing, low-grade fever, and anorexia are present for several days, followed by the onset of acute respiratory distress. Tachypnea or R6 terminus atypum. Wheezing, crackles or rhonchi on chest/lung. Auscultation. Intercostal and subcostal retractions. Pediatrics diseases of the respiratory system. Nasal flaring. Difficulty feeding due to increased aura that interferes with suckling and swallowing. Varying body temp from hypothermia to high DX. Based on clinical presentation, rapid viral identification can be performed on respiratory secretions obtained from nasopharynx. Elicit diagnostic test enzyme linked. Pediatrics diseases of the respiratory system. MX. Mild bronchiolitis can be treated at home with fluids, rest, humidification. Infants with respiratory distress are hospitalized. RX is supportive. Humidified oxygen to relieve dyspnea and hypoxemia. Parenteral fluids if infant is dehydrated or intakes. Poorly. Maintain semi-sit-up position to maintain airway. Pediatrics diseases of the respiratory system. 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 Clinical manifestations. Pneumococcal pneumonia. Infants. Preceded by mild urti for several days. Abrupt onset of fever, restlessness. Apprehension, respiratory distress. Grunting respirations. Nasal flaring. Supraclavicular, intercostal, and subcostal retractions. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Staphylococcal pneumonia. Prior urti with abrupt onset of high fever, cough, tachypnea, grunting respirations, sternal and subcostal retractions, nasal flaring, cyanosis, anxiety. Pediatrics diseases of the respiratory system. 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 NRGDX. Ineffective airway clearance RT bronchial. Obstruction. Ineffective breathing pattern RT increased. Mucus PDN. Impaired gas exchange RT increased mucus. An accumulation of exudates. Fluid volume deficit RT fever decreased. Intake and tachypnea. Knowledge deficit RT to DZ process. Pediatrics diseases of the respiratory system. 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 RX. Met. Antibiotic therapy CAF 25m/kg/Roman 4 6-8. HRLY until improvement, then oral up to 10 days. Alternatively, ampicillin or benzylpen with Gent 7.5m/kg/Roman 4 for 10 days. If PT does not improve in 10 days, switch to Gent 7.5m/kg/Roman 4 with clocks of 15/kg IM/Roman 4 6 for staph pneumonia when child improves. Continue with oral RX for 3 weeks. Pediatrics diseases of the respiratory system. 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 Bronchial breath sounds. Crackles. Abnormal vocal resonance. Consolidation. Pleural rub. RX. Admit. Antibiotic therapy, benzylpen or ampicillin. 6 for 3 days. When child improves, switch to Amixil 15/kg/TDS for 5 days. Pediatrics diseases of the respiratory system. 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 Asthma. A chronic inflammatory condition with reversible airways obstruction characterized by episodes of wheezing and cough. Etiology. Predisposing factors: allergens, heredity, cold air, smoke, fumes. Pediatrics diseases of the respiratory system. Viral infections, stress, exercise odors, drugs particularly aspirin, NSAIDs, house dust, dust mites, moles, animal dander, pollens, weeds. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Abdominal pain secondary to the strain placed on the abdominal muscles during labored breathing. A hunched over sitting position with arms braced. Fatigue is evidenced by difficulty performing simple tasks such as eating, walking, even talking, owing to SOB. Sudden or insidious onset of asthmatic episode. A feeling of chest tightness prior to onset of pediatrics diseases of the respiratory system. Worsening of asthmatic episode ongoing to bed owing to increased narrowing of the airways at night and pooling of secretions. At the beginning of the asthmatic episode, wheezing may be heard only with stethoscope. As the severity of the episode increases, wheezing is audible to unaided ear. Children who have severe respiratory distress may not demonstrate wheezing owing to decreased air movement. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pathophysiology. Asthma is irreversible obstructive airway disease, characterized by bronchospasm resulting from constriction of bronchial smooth muscles, inflammation and edema of the mucous membranes lining the airways, accumulation of thick mucus/secretions in the airways, increased airway responsiveness to a variety of pediatrics diseases of the respiratory system. Children with asthma have hyperactive airways. Normal airways react to irritants and other stimuli by narrowing. The asthmatic child's airways, however, narrow in response to stimuli that do not affect non-asthmatic individuals. When exposed to an irritant, whether allergic or non-allergic, the asthmatic child's bronchial smooth muscles go into spasm. Upon exposure to allergen antibodies. Pediatrics diseases of the respiratory system. Upon re-exposure to the antigen IgE, receptors are triggered to activate the mast cells, causing release of mediators e.g. histamine, leukotrienes, and other substances. The mediators stimulate both immediate and delayed inflammatory responses, which cause asthmatic symptoms. The immediate phase is characterized by bronchoconstriction that resolves in 1-2 HRS. The delayed phase, bronchoconstriction, may. Pediatrics diseases of the respiratory system. Late response may also occur inflammatory in nature and causes hyperresponsiveness, so airways that last several weeks or months. During an asthmatic episode, the mucous membranes lining the bronchioles become edematous and secrete large amounts of thick mucus, leading to increased airway resistance and respiratory distress. Because small airways are normally wider on inspiration and expiration, the child is able to. Pediatrics diseases of the respiratory system. Wheezing heard when air is forced through narrowed air passages during expiration. The child is able to inhale with difficulty exhaling. Air is trapped, causing hyperinflation of alveoli. Hypoxia results due to inadequate oxygenation of the lungs. Tachypnea is as a result of child struggling to get enough air. There are increases. Tachypnea reduces carbon dioxide levels in the blood. Hypocapnia. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Status asthmaticus. Increasingly severe asthma that is unresponsive. The vigorous conventional management. Predisposing factors. Infections. Inhalation of air pollutants and allergens to which the patient is sensitized to. Non-compliance in taking medications including overuse of bronchodilators. Aspiration of gastric acids. Pediatrics diseases of the respiratory system. 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 Monitor serum electrolytes. Administer humidified oxygen via tent, nasal cannula or face mask. Woman fall line for fluids and medications. Nebulize salbutamol. Oral or parenteral corticosteroids. Bronchodilators methylxanthines aminophyline or thefillin. If above fail, S/C epinephrine 0.1/kg. Endotracheal intubation with mechanical ventilation. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. NRGDX. Risk for suffocation, RT bronchospasm. Bronchoconstriction, mucosal. Inflammation/edema, bronchosecretions. Effective airway clearance, RT bronchospasm. Bronchoconstriction, mucosal. Inflammation/edema, bronchosecretions. Fatigue, RT hypoxia and increased work of breathing. Anxiety, RT respiratory distress and hospitalization. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Nebulize salbutamol. 2 minus 4 moles of sterile water plus 2.5 unk salbutamol. Give 4-HRLY reduced to 6 minus 8 as child improves. Salbutamol with a spacer device. Introduce 2 minus 3 pos salbutamol in the spacer chamber. Allow 3 minus 5 normal breathes. Repeat 4-ly, reduce to 6 minus 8 following improved. A face mask can be attached to spacer instead of mouthpiece. Pediatrics diseases of the respiratory system. Pediatrics diseases of the respiratory system. Aminophyline. If child does not improve on the above Rx. Initial dose 5 minus 6 unk/kg, then maintenance dose 5 unk/kg 6-ly room for over at least 20 min 1 hour. Antibiotics. In case of fever and other signs of infection, e.g. bacterial pneumonia. Supportive care. Fluid. Encourage BF. Pediatrics diseases of the respiratory system. 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 Pathophysiology. TB is most often transmitted by inhalation of contaminated droplets coughed up and expelled from an adult or adolescent with infectious PTB. The most common site of organism implantation is the respiratory tract. The bacillus multiplies in the lung tissue, alveoli, and regional lymph nodes. After incubation period of 2-10 x, hypersensitivity develops at that time. The pediatrics diseases of the respiratory system. Most infected children are asymptomatic at the time of initial positive skin test. The DC of TB is differentiated from TB infection by the presence of clinical manifestations. Usually untreated infections become dormant and never progress to clinical DC in healthy individuals. The immunological response of most individuals is usually strong enough to keep the bacteria from multiplying and spreading. Pediatrics diseases of the respiratory system. TB bacilli can remain dormant and cause active TB at a later time if child's resistance is lowered. If the lesion does not heal and is not walled off, it may continue to spread into nearby tissues, or it may enter the bloodstream and spread to other sites such as middle ear, brain, kidney, bones, joint, skin. TB destroys host tissue. When tubercle bacilli multiply, they may damage tissue so badly that the center of the infected. Pediatrics diseases of the respiratory system. When this liquid escapes through an airway, it may be coughed up as sputum, leaving a tiny hole cavitation in the lung. Clinical manifestations. Malaise. Prolonged fever strokes. cough for more than 30 days, growth retardation, unexplained weight loss, anorexia, pediatrics diseases of the respiratory system, lymphadenopathy. Others are related to the site of infection, e.g., kidney, brain, bone, lungs. DX. Initially skin testing, e.g., intradermal mantle. Test in children is plus VBDN. 3 minus 6 weeks of infection and as long as 3 months of infection. Children with plus V skin test can then undergo other tests, e.g., CXR, sputum culture and smear. Pediatrics diseases of the respiratory system. 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 Pediatrics diseases of the respiratory system.